Thank you. We are switching positions with Ben. Yes. Okay. So my second talk is on diagnostic pathways in hereditary autoinflammatory diseases. You will see that some things are somehow overlapping with the Israeli FMF experience, but the thing is now we are talking on very rare diseases, and of course in our practice these diseases would be rarely seen. So I would try to convince you that genetic diagnosis is very important for this group of diseases. So in my presentation, I would like to show particularly clinical aspects, how to approach these patients, what would be our evaluation in general, and then specific for these three diseases, CAPS, TRAPS, and hyper-IgD, and some suggestions for diagnostic workup. First, I would like to somehow raise this definition that was nicely showed by Fabrizio De Benedetti once, and I like this definition of autoinflammation as unexplained episodes of inflammation in the absence of any triggers. So this would be typical, let's say, in CAPS patients, in TRAPS patient. Hyperinflammation, a typical example would be, for example, Kawasaki syndrome or multisystemic inflammatory syndrome, where we had a trigger that caused excessive inflammation, and autoimmunity is aberrant adaptive immune response. So fever, when the child is referred, I'm pediatric rheumatologist, so when a child is referred to pediatric rheumatologist, this fever is not a simple fever, it's longer duration, no clear localizing signs. A number of laboratory tests has been already performed, and it was raised. Of course, with recurrent fevers, we first have to exclude other diseases, infections, autoimmune diseases, malignancies, even factitious fever rarely. What would be common symptoms that would kind of guide us that we should suspect that this could be some underlying hereditary autoinflammatory disease? So first, unprovoked systemic inflammation. The period should be over a period of 6 months. Characteristic rash I will show for some of the diseases. Headaches I would link with irritability. These children are, you are coming into the room and the parents are immediately saying, oh, he doesn't like doctors, he's always crying, you are trying to examine, but the child is really kind of a unwell, unhappy child. Irritable in adults, it could be emotional lability. I'm not treating adults, but in children, it's irritability. Musculoskeletal complaints are often, abdominal pain. Again, kids are often complaining of some abdominal pain, but these are a little bit more persistent, recurrent eye involvement. If you see all these children with suspect autoinflammatory diseases should be seen by ophthalmologists. Some of the diseases have lymphadenopathy, and fatigue is, like when you have infection, you are tired, you don't feel well, and these children have like a continuous or recurrent infections. In general, compared to some autoimmune diseases, when they start and are worsening, autoinflammatory diseases have more like a longer course. It takes usually a little longer time for damage, but it depends also on the kind of a disease phenotype that the patient has. You already seen this Eurofever Printo classification criteria, and I will not go into details, but strongly suggest that you read this reference. I will just focus on CAPS. These are classification criteria, and classification criteria, as you know, have low sensitivity and have a high specificity. You can see that for CAPS, for example, the patient requires presence of a confirmatory NLRP3 mutation and +2 of the typical presentations. And arthritis, for example, is not included. I will show you later the diagnostic criteria. For clinical classification criteria, it's a little bit less specific, a little bit more sensitive, but still not for clinical, let's say, diagnosis. For example, in CAPS patients, they would have typical, I don't have a pointer, they have these typical manifestations, but for example, arthritis and arthralgia would not be regarded as a clinical manifestations, only skeletal abnormalities. So you saw, and these are late manifestations. So in clinical practice, you really I often say I do not want to see a patient with full-blown clinical manifestations of any of these syndrome, because this means that we as physicians failed to diagnose this child earlier. So initial workup in a child with recurrent fever, of course, would be a detailed physical examination, infectious workup, imaging, and you saw very nicely the workup that is for inflammatory markers, including serum amyloid A, the same as was explained for FMF. We also find serum amyloid A as one of the best markers between the fever episodes. Of course, in every of these patients, we try to confirm also with ESR and CRP during the episode. I would say that this is one of the most important slides for my today's presentation. Why? Because your colleagues told me that you do not have genetic testing available for hereditary periodic fevers in Romania. My view would be that in a 19 million country, you should not rely on anybody else, that this is one of the, not emergency, urgent needs that you establish your own genetic lab that would do hereditary testing for periodic fevers. In our countries, we have low incidence, and genetic confirmation is very, very important to somehow confirm the diagnosis and to move forward. We first started with our pediatric cases, but now adults are regularly sending to our lab. And I think that you, as a country, cannot rely on some outside private lab, not just, you know, for the kind of a development, research, and everyday contacts, but also kind of these are genetic information, and I think that this is genetic data from your population, and I'm not comfortable to send these kind of you know, for the whole group of patients to some other lab. This is my personal opinion, and this is how we see at this. Single gene research and Sanger testing very rarely. If you have familial variant, and for example, FMF, in a, if it is used just for the prognostic reasons, but otherwise we do not do Sanger testing, except in familial cases. We do autoinflammatory gene panel with more than 30 genes, and usually link this with autoimmune genetic panel, so that we have the full screen. For familial cases or for some unusual cases, we would do whole exome sequencing. Often with the genetic testing, of course, you come with a challenging interpretation of VUS, variant of unknown significance, and then you search the InFevers database, search for pathogenicity of these genetic variants. Of course, it is difficult to perform functional testing. If the patient was already described as a pathogenic, it is easier, but sometimes you see these variants of unknown significance and have to interpret in your patients. For example, we have sister and brother. Father is from Turkish descent. They have a clinical picture very similar to FMF, but let's say a variant that was described as a variant of unknown significance. So sometimes it is not easy to describe. When you have a diagnosed patient with autoinflammatory hereditary disease, it is very kind of a, we give every patient, parents, the sheet of autoinflammatory disease activity index. It's actually, it sounds very kind of sophisticated, but it's a very simple questionnaire. The parents just click 1 or 0 for different clinical manifestations every day when these symptoms appear. At the end of the month, you count these, you summarize these numbers, and you see the autoinflammatory disease activity index. It is important because parents are then kind of how to say, sensitized to measure and to mark the symptoms during the fever attack, so that you have a good monitoring of the patient. I would say the second most important message, one is genetic testing. The second is multidisciplinary team for management of autoinflammatory diseases. And I will here briefly mention the EULAR points to consider for training in rheumatology, where I participated as a pediatric rheumatologist. And as a part of these points to consider, we evaluated what are the most important knowledge, what are the most important skills that rheumatologists should acquire during training. In Denmark and in Netherlands, they said working in teams. And in my country, it was knowledge. But, you know, knowledge, we learn knowledge in, let's say, in medical faculty, and knowledge is, how to say, is alphabet. We should know knowledge, but for making another step, I think knowledge is not enough. We should somehow combine knowledge of different specialists. It's easy to say, difficult to establish. So we are meeting once every month as a clinical immunology conference, where all the other specialists, geneticists, immunologists, hemato-oncologists, infectologists, rheumatologists, we are meeting, we are discussing our difficult patients, and then kind of decide what is possible to do in our lab, what is not possible, what we will send abroad. Management of autoinflammatory diseases, of course, the aim is early and rapid control of disease activity to prevent disease-related damage, and also, as for other rheumatic diseases, also treat-to-target principle applies for autoinflammatory diseases. That's why it is important to have the index of a measurement tool for disease activity to assess this, and to try to kind of monitor every 1 to 3 months to somehow adapt treatment if needed. Damage that could be associated is pretty much, was mentioned also for familial Mediterranean fever in children, for these most severe hereditary autoinflammatory diseases, growth failure, puberty delay, but also organ damage, as you can see here on this slide listed. Now I would like to move on these 3 typical examples. So CUPS, TRAPS, and HITs. These are part of the inflammasomopathies. The mechanisms are gain-of-function mutations in genes that generate inflammation, but also loss-of-function mutations in some genes that suppress inflammation less frequently. On the CUPS, we already discussed that this is caused by the NLRP3 mutation that promotes spontaneous release, constitutive release of IL-1 beta. You can see here the most prominent clinical features of CUPS. In pediatric patients, for those patients that we kind of diagnosed urticarial rash in the first year of life or during infancy, so these were children, as I said, unhappy children that were seen for several months by pediatrician with urticarial-like rash, all the time high inflammatory markers. Sensorineural hearing loss and chronic aseptic manifestations are usually a little bit more later manifestations if the chronic meningitis is ongoing, and I showed you the skeletal abnormalities. Of course, epiphyseal overgrowth will not be early manifestation. This is a late manifestations of disease, and we all as physicians should focus on these early manifestations: fever, rash, inflammatory markers. CUPS syndrome has a clinical phenotype from the most severe, CINCA to the least severe, a familial cold autoinflammatory syndrome. FCAS can be, of course, diagnosed also in adult population. These are mainly seen by adults, but CINCA is typical pediatric disease. The disease severity for NOMIT is usually the most severe. And this is what I already somehow mentioned, the diagnostic criteria for CUPS that are different from classification and clinical classification criteria. You might see here that there is no genetic kind of a confirmation needed, raised inflammatory markers, and more than 2 of the CUPS typical signs. As I said, skeletal abnormalities are late manifestations. Sensorineural hearing loss, I don't want to see child to have it at the time when I would diagnose these children. And I don't want to have kind of a chronic aseptic meningitis when I would diagnose these children. So that's why I'm kind of urged that the genetic diagnostics with the very first suspicion is crucial. When I spoke with Ivona Aksentijevic from NIH, she said every child with PFAPA would undergo NGS and you know, this was 5 years ago. Of course, at NIH they have different kind of funding, but definitely we do not see so many children with hereditary autoinflammatory symptom that we would not perform the full NGS panel in this group of patients. This is one of our patients. They have this subcortical and periventricular changes that developed in spite of the long-term treatment. This patient was treated with anakinra. It was regarded that anakinra crosses the blood-brain barrier a little bit easier and is somehow better for CNS involvement, but this was not the case in this patient. Then because of the injections, we switched her on canakinumab. What are the specific examinations in CAPS patients? For every patient, assess muscle strength, neurological status. All of these patients should undergo regular hearing screening, so we do regularly, and one of our patients have some mild changes in this high-frequency audiogram. So these are kind of mild changes that we see in these patients. Ophthalmological examination, renal, and for severe phenotype, of course, you should do imaging and the full range of cognitive testing. You have already seen the success of CAPS treatment. It was already in 2009 shown the canakinumab therapy success in patients with CAPS. What are other treatments not very successful because the canakinumab and IL-1 blockade is really the targeted treatment. Some patients might require also some symptomatic for short-term use. You should, of course, employ also supportive therapies when needed. I do not have time to go into this consensus treatment. What I would just like to highlight, you will see on the left-hand side on-demand therapy and on right-hand side continuous therapy. In our experience, on-demand treatment for those patients that are diagnosed in pediatric population is not applicable for CAPS patients. We have all patients on continuous treatment, and it really depends whether on anakinra, canakinumab, and what would be the dose of therapy. TRAPS syndrome is the second syndrome that I would like to highlight. It's an autosomal dominant disease, very important for diagnosis. We have one family with 3 affected members, grandmother, mother, and a child. The child was diagnosed, so grandmother and mother had confirmed TRAPS mutation. And the daughter came during COVID with a typical symptom of conjunctivitis, high fever during COVID. So Miss C would be, so she would be, she fulfilled the diagnostic criteria. So myalgia, conjunctivitis, she fulfilled the criteria for Miss C, but because of this family history, we immediately performed genetic testing, and in 2 weeks' time, she had confirmed TRAPS familial mutation because we did Sanger testing. So this is also the ease of genetic diagnostic. So positive family history for TRAPS is important. Gene encodes the type 1 TNF receptor. All mutations are located at the extracellular part of the protein, and it somehow impairs the TNF binding or the defective shedding of the TNF receptor, which causes the inflammasome activation. Some of these patients are also responding very nice to anti-TNF treatment. Clinical features, long febrile episodes in our patients, these were usually 2 or 3 weeks. But if you are treating with anti-IL-1, for example, if you are giving anakinra, it is like, you know, drop the next day, they would be fine. So they can get also anakinra on demand. So different as CAPS, this, in our experience, TRAPS patients, some patients, TRAPS have very nice response to anakinra on demand. They have myalgia, but not due to myositis, but due to fasciitis, and they do not have elevated muscle enzymes. They have migratory skin rashes, and I will share with you this image. This was a patient who was diagnosed by our adult colleagues. We presented the hereditary autoinflammatory fevers at the rheumatology conference, and after the meeting he said, I have one strange patient that I am following for several years who has all the time high inflammatory markers and has this migratory rash, and you can see here. And he was, this was the oldest patient at the time diagnosed with TRAPS. We published this in 2011. Patient was started with etanercept and had a first time in his life as he was diagnosed with as he was followed by rheumatologists, he had normal inflammatory markers. So TRAPS clinical features, other acute synovitis, ocular involvement, abdominal pain. I have to speed up my presentation. The clinical features I already mentioned, the febrile attacks. Some of patients, as the patients with the skin rash, had these kind of a febrile episodes, subfebrile episodes, longer, that are also described in TRAPS patients. So the typical specific TRAPS examinations would be ophthalmological examination, the genetic testing and renal function, and I already mentioned that muscle enzymes could be normal. You saw this study that included FMF, colchicine-resistant FMF, TRAPS, and hyper-IgD patients, so I will not go into details for the canakinumab use, just that you are aware that canakinumab is an excellent treatment for TRAPS, was shown as effective and safe treatment. Some patients require also non-steroidals and glucocorticoids to somehow relieve the symptoms of fever, and I already mentioned that we are sometimes using also off-label TNF inhibition with etanercept that are successful in some patients, and similar on-demand treatment, I would say, in TRAPS patients. It is in a certain group of patients, and those that have signs of chronic inflammation, continuous treatment. The last group of diseases that I would like to focus is hyper-IgD and mevalonate kinase deficiency. This is a metabolic disease. Another example how metabolic disease can cause autoinflammation. Gene is mevalonate kinase. The most severe is mevalonic aciduria, where there is complete absence of enzyme activity. Hyper-IgD has a kind of a partial, up to 10%. This enzyme mevalonate kinase is the second step in cholesterol synthesis. The patient with hyper-IgD the first patient that we diagnosed was a patient that was followed by several physicians, pediatricians, unhappy child, and then she developed gastrointestinal, it was actually fistula, gastrointestinal. So the gastrointestinal inflammation was so severe. She had this lymphadenopathy that is typical for a hyper-IgD patients, abdominal pain. It's a basically metabolic disease. These patients can have also hepatosplenomegaly. We haven't seen skin rash in hyper-IgD syndrome patients. The disease, hyper-IgD, starts very early. Usually all patients start less than 1 year of age. So if you have less than 1 year of age, patient, CAPS or hyper-IgD are the most kind of a common differential diagnosis. And they have kind of a variable episodes between attacks. Regarding the specific examinations in hyper-IgD syndrome, I would like to highlight particularly at the diagnosis, if you do not have capability for genetic testing, mevalonic acid in urine is elevated because it's a metabolic. The syndrome has name hyper-IgD syndrome because serum IgD is elevated, but this is not specific nor sensitive testing, so it should not be somehow. As I already stated, genetic testing is very important. This is one slide showing the daily urinary mevalonate during the attack and success of canakinumab also in mevalonate kinase deficiency, hyper-IgD. And this is the growth curve. The lowest is the growth, the weight curve, how patient was gaining weight. You can see after starting canakinumab, she immediately increased weight. She became happy child, and actually parents were extremely satisfied with this treatment. For other treatments in hyper-IgD, sometimes these patients, it is described that they can develop macrophage activation syndrome. Some patients are treated with etanercept and tocilizumab. We do not have this experience. Colchicine is completely ineffective because it is a metabolic disease. Consensus treatment plan is pretty much similar, on demand and continuous. in our experience, continuous treatment. And I would also like to mention that for mevalonate kinase deficiency in severe patients that are non-responsive to treatment, also allogeneic, not autologous, but allogeneic hematopoietic stem cell transplantation is one of the viable treatment options. So to conclude, broad clinical disease spectrum of all these hereditary periodic fever syndromes. Clinical phenotype somehow guides the genetic testing, and I would like to highlight that treatment decision is somehow guided by our assessment of disease activity, our assessment of disease severity, and estimation of future risk. Thank you very much.